Chris Taylor and Tim Robinson. And Nicole, unfortunately, couldn't join us today, but they're going to talk about the Academic Health Science Network, and they're going to facilitate a conversation about real-world evidence and how it can play a part in shaping the NHS. So, Chris and Tim, over to you. And then after their presentation, we'll have a well-deserved tea break.
Hi, thanks very much, and thanks for inviting us to be part of the workshop today. As you've already said, in a late change to the advertised lineup, Nicole unfortunately isn't available. She's unwell, so she asked if I would come along. So you'll have to make do with me today, rather than Nicole. So I'm Tim Robinson. I'm the commercial director at East Midlands AHSN. I think some of the things that we're going to explore in the session, in this session, will be a nice build on some of the questions and the conversation that's just taken place, prompted by Ian's presentation. So I'll be presenting today on behalf of East Midlands AHSN, but many of the slides that you'll see will also apply to the West Midlands, and we've got contact details for both organisations later in the presentation. And the presentation really will come from more of an innovation angle rather than pure research. So it'll be around how we get that implementation into real world practice, recognizing that both are closely linked. So hopefully you can all see. Chris, is my slide showing? Is that good? Thank you very much. So quick, just to give it a context in case people don't know. So the AHSN network, so East Midlands AHSN is one of 15 AHSNs. We cover the whole of England. We're commissioned through NHS England and NHS Improvement, and also the Office of Life Sciences. What that means is that we effectively operate as the innovation arm of the NHS. That includes supporting nationally selected innovations to get traction locally, and also working locally on local programs of work that we try and magnify in amplitude out to regional and national. And hopefully we'll cover across some of those today. And I think another important point really is that we do operate as a network, and we are able to both import and export proven innovations from other areas. So the way in which we're funded and where we're positioned within the system does give us a unique role. And I think in the context of ICSs, we are very well positioned to support the innovation agenda within ICSs. We've got a unique set of expertise and knowledge around how to get innovation adopted and sustained. And I've got some examples of that later on. We work cross-sector. We cover NHS social care. We work with councils. We work with academia. We work with research organisations. We work with industry partners. And within that, we've got strength and depth in connections that can bring together some very interesting collaborations. And I think the other thing, the fact that we operate nationally, means that we are able to be very cognizant of what local needs are, but also very aware of what's happening outside of the East Midlands. So we operate in a way that will hopefully bring value both locally and nationally. One of the key assets that we have developed as an AHSN network is both the pipeline and our approach to that. So in the AHSN network pipeline, we've got access to over 1,000 evidence-based innovations. Now, some of those are early stage and some of those are later stage. So on this here, we've got a graphic which kind of shows the way in which we classify items within that pipeline, moving through from discover into develop, which is where we undertake our proof of value, real world evidence projects, then into deploy, which is supporting the rollout at scale of proven innovations, And then the thing that we talked about as well is how you get that sustained. So the business case and that funding mechanism being in place to support those proven innovations. So we operate across the full range of activities. We are a relatively small organization. So in total, we are around about 60 people for the whole of the East Midlands, and that includes both our national work and our local work and the 3 commissions that we deliver. So this framework helps us to identify and prioritize that work that we do that will maximize the impact across the system. I think one of the interesting points talking about how we link in with the research infrastructure is to look at how we can bring projects that have got proven efficacy into that real world space, and how we can develop them into products and services that can then be scaled up with the appropriate real world implementation evidence that supports the business case to make it embedded within the system. So not to labor that, but I think it's a real key part, and based on the conversation we had earlier, I think that's a real key interface to explore. In terms of our offer to ICSs, key part we want to do is help to identify and define needs around innovation. One of the things that we do increasingly, and we're looking to expand, is bespoke horizon scanning. So we can look at a particular topic or area and look at the HSN pipeline, find innovations that are there that are able to implement now or are very close to that, so that you can build those into your thoughts and plans around addressing known problems. And the other thing that we do is where you've got proven identified need and there isn't a seemingly readily available innovation, we can put that call out to innovators who will want to work with systems to either develop or adapt solutions to meet specific challenges. So I think one of the things there is that we can work from both sides. So we can either look at proven innovation or from a problem perspective, and we've got the ability to support both types of activity. Within that, so one of the things I wanted to highlight was the way that research actually fuels is one of the inputs into the AHSN network pipeline. So this is an example of a program which is now being rolled out nationally, which is called Focus ADHD. It originally was the AQUA study, which was undertaken with the Institute for Mental Health and was funded by NAHR. It was the Clark at the time, they're now ARCS, East Midlands, and also NAHR Mindtech, the MedTech cooperative. Within that, we also provided East Midlands AHSN role really was around providing some real world evaluation resource to understand the cost benefit analysis and how the real world implementation of the technology was used. So the focus of Focus ADHD is around putting in place objective testing for ADHD. It's embedded into assessment pathway for young people. It's now being used in over 60 trusts and 117 sites across England. And based on the evaluation that we've done, it's estimated that around 62,000 appointments have been saved in the NHS and over since 2017, which is around 10 million and 10 million in actual savings since April 2020. And I think that this is a real good example of taking proven research through a local HSN, and then we then signal this as ready for wider spread, and then we've been able to support that as an HSN network to support rapid scaling and adoption leading to significant spread and significant impacts. I know this is not directly linked to health inequalities per se, but just want to use this as an example of how the mechanism can work and how we might apply some of that same methodology and approach to other projects. So I'm just going to move on. So this basically is showing how the inflection chart of how AHSN support was able to accelerate the uptake of that product or that intervention diagnostic within that pathway. It's not an intervention. And there were some of the highlights there. Talked about it before, but around over half the trusts in England are now using the innovation to support their ADHD assessments. There's still further to go, but the programme and support is there. And as part of that work, East Midlands AHSN developed implementation packs, communication toolkits, business case. So everything that's needed from an organisation to be able to review and undertake and build their own business case to take the innovation forward. So it's a little bit of the kind of model for how the kind of happy path works in this world. And there's lots of learning that we've taken from it and understanding how innovation, what conditions are needed, and what are the things that you need to have in place in order to ensure the best possible opportunity for scale up and spread of an innovation. And just looking at the network a little bit wider, just wanted to touch on a key part of our strategic objectives for 2021 to 2026 is to increase the number and depth of impacts through outcome-led programs. In order for programs to have impact, we need the research and the outcomes from there to flow through into the pipeline so that those can start to feed the scale-up process. And in terms of reviewing adoptions for approaches, we kind of take our own work and we evaluate that. We want to understand what makes things tick. So it was actually published in May 2021. We identified learning from across the AHSN network about methods to spread and adopt innovation with partners in health and social care. The study, flick forward. Sorry about that. The study was designed to answer a number of questions, including what are the different approaches to spreading interventions that have been developed and applied by AHSNs. Sorry, can't speak. What are the contextual factors that enable or challenge different approaches to spread? How do theoretically informed are the approaches? Have national policy frameworks influence the approaches? And what inferences can be drawn from a comparison of the different approaches across different national programs that the AHSN network has delivered? I mean, it's well worth a read. I don't know if you've got a direct link into that, but we could share that link afterwards if that's helpful. If not, I think if you Google it, you'll find it. It is on the AHSN network website. And there were four main themes that came out. And those are summarized on the slide. I'm not going to read them out to you there. But I think what that does is kind of start to try and answer some of the questions, and that can be applied at both local and also to help inform policy around what are the conditions, what makes things work, what makes things spread, what makes things have the ability to scale up, what do you need to do? And that can be looked at individual organization level, at ICS level, or at regional level. So just really wanted to take the opportunity just to kind of lay out where our priorities are currently aligned. So our priorities evolve because we're responding to both local and national drivers. So key areas for us are CVD, mental health, workforce, polypharmacy, wound care, patient safety. And underpinning that, we've got cross-cutting themes, health inequalities being one, focused around the core 20+5 strategy, digital innovation, sustainability and achieving net zero, workforce, and patient safety. So there's lots there, but there's lots that, but this is just an articulation of where the focus of our work is. If something isn't on there, that doesn't mean that we won't support, help develop through our local program work. This is an articulation of when we come together as an AHSN network, where the priority areas are that we've identified. So that's linking into different national drivers, and this is a priorities that we've agreed with our various commissioners from AHSE, AHSI and Office for Life Sciences. Having talked around using some examples of the programs, thought it would be useful to just spend a couple of minutes talking about the different ways in which we can offer support and expertise for the ICSs that we work with. We've got our portfolio of national and local innovations. Some are at different stages of development that we're supporting or working on within those. We have our local innovation exchange process to respond to local challenge statements. We have one on an event on this week, which is around cardiac rehab, and that's been co-developed with the physiological, I've forgotten the name of it, the physiological measurement net, I've forgotten, physiological sciences. I'm not guessing, I'm floundering there, I can't remember the exact name, so I'll move on. But it's been co-developed with one of the groups across the Midlands region, and we're running that this week. We helped develop a series of challenge statements, and we've got bringing together those people that have got challenges and organisations that may have answers to some of those questions to try and develop some programs of work and link people together. I think the other thing that we have is that, as well as our innovation portfolio, that kind of only tells part of the story. A lot of what we do is providing expert services and insight from within our team. So we've got expertise in evaluation, data-driven insight. We're also key around supporting enabling economic growth and active in patient co-production of innovation. What I've tried to do on this slide is just bring together a number of these services. And if any of those resonate with you, please do reach out, and we can have a conversation about how we may support or help activities within your specific areas. And one of the things I wanted to highlight was the Innovation Academy. So this was originally developed last year in response to the kind of commonly asked questions that we get from the innovator community that we support through our Office for Life Sciences Commission. However, we've had massive amount of interest from system partners as well. So it covers off common topics, and what we've got is a free, open for anyone to sign up. There are pre-recorded webinars, and then we host live Q&A sessions on each of those themes throughout the year. We've got lots of NHS and social care people signed up and are accessing those resources, and we've had some great feedback. The link's there again. We can make that available after the meeting if people want to take a look at that. Okay. So in terms of kind of trying to stimulate some of the discussion, we thought that there were 4 questions that we had identified. So this is not in any way to try and corral everything into these 4 topics, but these were the things that we were interested in. So how do we identify the innovation needs across the East Midlands? There are lots of problems. There are lots of things that the AHSN network could help with, but focusing really on where we think innovation's got a role to play. We really want to understand what the enablers and barriers are to organisations when they seek to adopt innovation. A reference before the work that was done through the AHSN network to look at adoption and spread of innovation, but we're constantly learning and evolving. So I'll be interested to find out if there's anything that people particularly think is a problem. We can't always solve that locally within the East Midlands AHSN, but we do have good connections in, and we're often asked to help inform future policy and funding national remit. So it's always very helpful to have strong articulation of real problems that we can feed into those conversations. Looking at culture and behaviours, what does an innovative organisation look like? What are the people conditions that are needed, the organisational dynamics? What does that look like? And then the last question from us was getting innovation adopted, but also making sure it's sustained. And after the programme or the project or the pilot's finished, how do we make sure that the good innovation stays in place and continues to be used to benefit patients within the East Midlands? So I'll pause for breath there and go back to the chair and see if we want to open up for questions.
Yeah, thanks so much for your presentation, Tim. Very illuminating, all the stuff that you're doing. If you want to take your slides down, that'd be fantastic, so we can all see each other.
That better?
Great. So any questions for Tim and also Chris as well? Any questions, anybody?
Yeah, apologies, I forgot to introduce Chris, who's sat there. So Chris Taylor.
Yeah, we saw you did, Chris.
Communications and Engagement Lead. Sorry about that, Chris.
Don't worry, you did a fantastic presentation too. So, okay, so we've got Grit again. Is it Grit? Yeah.
Giri.
Giri.
Yeah.
How there, Giri?
Yeah. So Tim and Chris, I think a few years ago, the East Midlands, I think it was the AHSN, did some work around CVD prevention and focused on AF patients. And I think you put an intervention in with CCGs, I think it was, to try and increase uptake. And then I've got the initial report showing improvement, but I've not really understood what the intervention was in those CCGs and so on and so forth. The reason I'm raising that here is work like that, of course, is important because it might give us thoughts. It might get us to think about what intervention should we put in place across the Midlands. Across the Midlands, we got 1,300 practices, whereas I guess you would have worked with a couple of hundred practices in the CCJ worked in. So it's about, where you put interventions in and seeing it to work, perhaps to think about how you might scale it up across the whole of the Midlands.
So
thank you.
That program was around detecting atrial fibrillation, and it was using a point of care device. It was using the AliveCore diagnostic. So the program was actually designed to scale up to Midlands wide. So it wasn't a pilot; it was a scale-up program. It wasn't let's try this and see if it works. So the intention was that was scaled out. The resources were there. We were dependent on the how that was received, shall we say, by individuals. So that one wasn't a kind of let's try something small and scale up. It was an evidence-based program. It was nationally driven, and we were the agents for trying to support that change across the whole of the East Midlands. And all of the AHSNs in the 15 in the network all adopted that as a program. I'm going to pass to Chris because it was slightly before my time that program took place, and Chris has probably got some more context on that.
Yeah, so that was the project that Tim talked about earlier, the ADHD program. That was a national, that started in the East Midlands, became national across all AHSNs. So AF was similar. It was adopted across all AHSNs between 2018 and 2020. And as Tim says, it was based around detecting, but also around helping healthcare professionals to then offer optimal anticoagulation medication to those who were identified as being most at risk, and then also supporting patients with their own anticoagulation. So, you know, taking better control of their own care. So that was over 2 years, 2018 to 2020, and the AHSNs do a lot of work around evaluating their innovations. And over that 2-year period, I think it was around 3,000 lives that were saved through avoiding strokes, etc. And I think the savings are around £158 million in terms of NHS costs, and then around 100 million in terms of associated social care costs. So massive, you know, positive impacts on the system. And like Tim said also earlier on, the AHSNs, you know, we don't implement innovation, step back, and then expect it to fall off a cliff. You know, we do it in a way that it's sustained. So we've continued to monitor the impact of the work that we did with CCGs after we exited that program in 2020. And it's been difficult to collect the data during the pandemic, but the indications are that you know, the work that has been done is being sustained, certainly within these Midlands areas that we've been involved with. So it's a good example of another project that we're involved in with this for a certain period of time. We then move on to something else, but the impacts continue to be sustained and felt after we exit.
Okay, thanks for that response. The final question before we go for break is Chris.
Yeah, so thank you. When Ian talking at the start, he started off talking about, you know, what happened at the start of COVID and how we managed to move from a position of early ambition to full implementation across the country for various COVID interventions very, very quickly. Matter was probably sort of 3 to 6 months for some of those things. Tim, when you were talking, you described this ADHD assessment pathway, and essentially, I think what I heard you say was a sort of pattern of spread, which was sort of linear over, I think it was four or 5 years, reaching out to approximately half of the acute trusts across the country. And I just wonder, do we know what would enable us to have reached 100% of the acute trusts across the country in that 4 or 5 years, or possibly even, you know, do we know what would have allowed us to get full implementation maybe over 2 years?
Yeah, I think some of those early years were getting the real world evidence together and the pace to gather that. So I think that you start to get some momentum. I hosted a round table actually, and there was a link to this a couple of months back, where I was talking to some provider organisations around innovation and their approach. Everybody said that they wanted evidence-based interventions. Whenever anybody is doing a new project, nobody builds evaluation into their projects to generate the evidence to show the next organisation how it's done, because it's always one of those things that gets cut out of the business case because it's kind of seen as a nice to have rather than an essential. So I think with this, if we'd have been able to have more, as the evidence built, people kind of started to get on board, because it becomes, well, you tick off more boxes of, well, you haven't done that, have you done this? And it kind of goes through. What we ended up with was a comprehensive pack of resources that supported that innovation, from the posters you could put on walls to communicate to patients, through to kind of quite complex business case modeling around where the cost benefits were achieved, what the pathway needed to look like, even down to how do I move from my current state to my future state, so almost like blueprint implementation plans. Those are the artifacts and the resources that help to create that momentum, because people had confidence. I think doing something new takes a little bit of bravery, and generally there's a level of risk averseness because we're dealing with healthcare outcomes. We've got to take that into mind. That's not a criticism. I think your observation about COVID was that I think people accepted less evidence on things in order to adopt them. There was a more the risk profile went up because it was a need to, we need this now. It wasn't a, ooh, well, we'll sit and wait. And I think that you see that in normal times, an organization's desire to do something and implement something and the level of evidence that they need are inversely proportional. So where organizations really want to do something, they accept the fact that there might not be the full evidence base there, or the business case doesn't quite do this or doesn't quite do that. If they don't want to do something, then they want a business case that shows them a return on investment within 20 minutes of signing the contract with the supplier. So there is a big culture and behaviours element and a timing thing. So, you know what I mean, if you went to during the pandemic, if you'd got innovations that supported the management of patients in that particular circumstance, you were getting a lot more attention than if you went to trust at that same time with something that was, say, CVD related, or because that was it. So there's a kind of scale of priority. So I think all those factors play in, and what my view is that the things that we develop for the Focus ADHD program, having all those artifacts that I talked about, will not guarantee you scale up, but they will address lots of the known barriers to scale up and give you a better opportunity to get scale up. Nothing can be guaranteed, because at the end of the day, we're dealing with people, and organizations are made up of people and different views, different perceptions, different priorities. So I don't think there is ever going to be a perfect formula. We kind of, if we can get to 80 out of the Pareto's, or 80 and 20%, then we'll be doing pretty well.
Okay, thank you.
Okay, great. And thanks for your presentation, Chris and Tim. Lots of things to think about when we have our breakout sessions. We're going to have a 15-minute break, and then we're going to then have Professor Melanie Davis from the University of Leicester